Most people over 60 assume that if a medication is on the shelf, if a doctor prescribed it, if they've been taking it for years without a single problem, it must be safe for their kidneys. That if something were quietly going wrong, they would feel it. They would know. Some signal would come. I used to make the same assumption about my patients. I assumed they were being warned. That somewhere between the prescription pad and the pharmacy counter, someone was having that conversation. Then I started looking more carefully at their kidney function panels, the GFR numbers, the creatinine levels, in patients who had been on the same medications for years without a second thought. Damage that was clearly visible in the blood work and completely invisible to the person living in that body. A woman in her late 60s, 3 years of daily ibuprofen for arthritis, no prescription required, no symptoms, no reason to question it. A routine blood test revealed her kidneys functioning at 45% of expected capacity. A man in his early 70s, over 2 years on an acid reflux medication, he trusted completely. Felt perfectly fine. Silent kidney inflammation, already progressing, found only because we happened to run the panel. And what I found, in patient after patient, year after year, changed the way I practice medicine. Here's what the label never warns you about. Here's what almost no one tells you when they hand you that prescription, or when you pick it up off the shelf yourself. My name is Dr. Sophie Martin. I'm a urologist with over 20 years in clinical practice. And today I'm going to tell you the truth about 5 popular medications that are silently damaging senior kidneys, often with no warning signs whatsoever. 5 medications. What they're doing to your kidneys after 60, and exactly what to ask your doctor before you take another dose. Think about a water filtration system. A brand new filter moves water through cleanly, efficiently, handling whatever you push through it with ease. Now think about that same filter after decades of continuous use. The structure is still there. It still works. But it moves more slowly. It holds on to things longer. And when you push the same volume of chemicals through an aging filter that was designed for a newer one, the damage accumulates in ways the manufacturer never calculated for. Your kidneys work the same way. After the age of 40, kidney function declines by approximately 1% every single year. That means by the time you are 70, your kidneys may be operating at 60 to 70% of the capacity they had in your 30s, even if every test has come back normal, even if you feel completely fine. Normal for your age is not the same as the kidney function your medications were designed for. Here is what that means in practice. A senior kidney clears medications from the bloodstream more slowly than a younger one. Drugs accumulate. Levels build higher than intended, higher than the dose on the label was ever calculated to produce. And dehydration, which is extremely common in seniors and often goes unnoticed, compounds that affect significantly. When the body is even mildly dehydrated, blood flow to the kidneys drops, and whatever medication is circulating in that bloodstream becomes more concentrated, more toxic, more damaging per dose. Here is the part that stops people cold. Nearly 40% of adults over 65 take 5 or more medications every single day, a reality documented extensively by the Centers for Disease Control. And according to research published in the American Journal of Kidney Diseases, patients over the age of 60 account for more than half of all drug-induced kidney injury cases reported in clinical settings. More than half? The medications on this list are not inherently dangerous. What makes them dangerous, specifically for you, specifically after 60, is the combination of a kidney filtering more slowly, a body holding medications longer, and a conversation about what that means for your kidney health that almost never happens. That conversation starts right now. Medication number 1, ibuprofen and naproxen. Ibuprofen is the most purchased over-the-counter pain medication in the world. For seniors managing daily arthritis, joint stiffness, or chronic back pain, it feels like a lifeline. Safe, familiar, no prescription needed. Most seniors have been taking it for years without a second thought. But here's the truth. NSAIDs work by blocking chemicals in the body called prostaglandins, the same chemicals responsible for inflammation and pain. But those same prostaglandins also maintain blood flow to your kidneys. Block them chronically and your kidneys begin operating under reduced blood supply day after day without a single symptom to warn you. In a younger kidney with full reserve, the body compensates. In a senior kidney already working at reduced capacity, that reduced blood supply becomes cumulative, silent damage. A study published in the American Journal of Medicine found that seniors over 65 who used NSAIDs regularly had a significantly elevated risk of acute kidney injury, with risk increasing sharply alongside existing conditions like high blood pressure or diabetes. Reduced renal blood flow, rising creatinine levels, accelerated decline in kidney function over time, progression toward chronic kidney disease, and in seniors with existing hypertension or diabetes, a significantly elevated risk of acute kidney injury serious enough to require hospitalization. If you take ibuprofen or naproxen daily for pain, ask your doctor this specific question. Given my current kidney function, is there a safer alternative for my pain management? Acetaminophen is far gentler on the kidneys at appropriate doses. Topical NSAIDs gels applied directly to the joint deliver localized relief with dramatically less systemic kidney exposure. The options exist. The conversation just has to happen. Medication number 2, proton pump inhibitors, omeprazole, pantoprazole, and their close relatives. Millions of seniors take a PPI every single day for acid reflux, heartburn, or GERD. Many have been on them for years, some for over a decade, and they feel completely harmless. It is a stomach medication. What could that possibly have to do with the kidneys? Here's what the label never tells you. Long-term PPI use has been directly linked to a specific form of kidney inflammation called acute interstitial nephritis, an immune reaction inside the kidney tissue itself that develops silently over months or years with no pain, no visible symptoms, nothing to trace it to. A landmark study published in JAMA Internal Medicine, tracking over 170,000 patients, found that long-term PPI users faced a 28% higher risk of developing chronic kidney disease compared to non-users, and a 96% higher risk of progressing to kidney failure. Subclinical kidney inflammation building without detection. Gradual GFR decline with no warning signs. Magnesium depletion affecting heart rhythm and muscle function. Increased vulnerability to infection. And in long-term users, over 70, measurably accelerated kidney function loss that compounds with every passing year. If you have been on a proton pump inhibitor for more than a year, ask your doctor, have my kidneys been tested recently given how long I have been on this medication? H2 blockers, famotidine, for example, offer acid management with a significantly lower kidney risk profile in many cases. Dietary modifications can reduce acid reflux without medication entirely. The goal is not to suffer with your symptoms. The goal is to make sure your stomach is not being protected at the expense of your kidneys. Have you been taking a heartburn or acid reflux medication for more than a year without a single kidney function check? Tell me in the comments. Oh, I want to know how many of you have never been told this was something to watch. Medication number 3, certain antibiotics, more specifically aminoglycosides, and long-term nitrofurantoin. When a senior develops an infection, a UTI, a respiratory infection, a wound infection, antibiotics are the obvious answer. And for acute infections, they are often absolutely necessary. The problem is not antibiotics as a class. The problem is specific types, used in a population whose kidneys are already less equipped to handle them. Aminoglycosides, a class that includes gentamicin and tobramycin, are directly toxic to kidney cells at a biological level. They accumulate inside kidney tissue and cause damage that is both dose-dependent and cumulative. In a senior with already reduced kidney function, even a single course can produce a measurable decline in GFR. A study in the Journal of Antimicrobial Chemotherapy found that elderly patients faced nephrotoxicity rates from aminoglycosides more than twice as high as younger patients receiving the same treatment. Long-term use of nitrofurantoin, commonly prescribed for recurrent UTIs in older women, carries its own risk of kidney and lung toxicity in patients over 70, a risk that is rarely mentioned at the point of prescription. Direct damage to the kidney's tubular cells, reduced ability to concentrate urine, acute kidney injury during the course of treatment itself. In seniors with existing kidney disease, permanent loss of function from a single treatment course, and with long-term nitrofurantoin, simultaneous lung and kidney toxicity developing side by side. Before any antibiotic course, ask this question. Is this the safest antibiotic option for someone my age and my level of kidney function? Many infections respond equally well to less nephrotoxic alternatives. And for seniors dealing with recurrent UTIs, ask your doctor about preventive strategies, D-mannose, vaginal estrogen therapy, probiotic protocols, before defaulting to another antibiotic cycle. Medication number 4, ACE inhibitors and ARBs, two of the most common blood pressure medications prescribed to seniors. These medications are genuinely important. They protect the heart. In diabetic patients, they protect the kidneys. Most seniors on them have been told they are kidney protective. And in many clinical situations, that is completely true. But here's what I need you to hear clearly. The danger is not the medication alone. It is a specific combination, one that nephrologists have named the triple whammy. An ACE inhibitor, or ARB, taken alongside an NSAID like ibuprofen, in a senior who is even mildly dehydrated. The ACE inhibitor reduces blood pressure inside the kidney's filtration vessels. The NSAID simultaneously reduces blood flow to the kidney, and dehydration drops overall fluid volume. 3 separate mechanisms, all reducing kidney perfusion at the same time. A study published in the British Medical Journal found that this triple combination raised the risk of acute kidney injury by more than 30 times compared to taking none of these factors in isolation. In a senior kidney, that triple hit can produce acute kidney injury within days. Acute reduction in blood flow to the kidneys, rapidly rising creatinine, a sign the kidneys are struggling. Acute kidney injury. In seniors with existing kidney disease, a permanent step down in function they will not recover from. In severe cases, temporary or permanent dependence on dialysis. If you are on an ACE inhibitor or an ARB, never take ibuprofen or naproxen without explicit guidance from your doctor. And stay hydrated, consistently, deliberately, because dehydration is the hidden trigger that turns a manageable situation into a medical emergency. Ask your doctor, are any of my current medications dangerous in combination, especially if I become dehydrated or unwell? Before today, had you ever heard of the triple whammy? What happens when a blood pressure medication, a pain reliever, and dehydration hit a senior kidney at the same time? Most of my patients had not. And that gap is exactly why kidney disease in seniors is so often caught far too late. Medication number 5. Certain diabetes medications, older agents, and SGLT2. Inhibitors in seniors with reduced kidney function. Managing diabetes is essential. Uncontrolled blood sugar destroys kidneys over time. That is not in question. The medications seniors take for diabetes are prescribed for serious, legitimate reasons. But here's what the conversation at the pharmacy almost never includes. Some diabetes medications require a minimum level of kidney function to be used safely. And in seniors whose kidneys are already quietly declining, sometimes without any formal diagnosis, continuing these medications without regular monitoring is a risk most people are never told they are taking. Metformin, one of the most widely prescribed diabetes medications in the world, is contraindicated in patients with significantly reduced kidney function because the kidneys cannot clear it efficiently. When it accumulates, it can trigger a condition called lactic acidosis, a dangerous buildup of lactic acid in the blood. SGLT2 inhibitors, newer medications like empagliflozin and dapagliflozin, work by directing the kidneys to excrete excess glucose through the urine. In seniors with already reduced GFR, that mechanism places additional daily strain on kidneys that no longer have the functional reserve to manage it safely. FDA guidance explicitly identifies reduced kidney function as a threshold below which several of these medications should not be used. Metformin accumulation in kidneys that can no longer clear it efficiently. Lactic acidosis, presenting as nausea, weakness, and difficulty breathing. In seniors with unrecognized kidney disease, a life-threatening metabolic emergency with little warning. SGLT2 inhibitors below a safe GFR threshold. Recurrent urinary tract infections, dehydration, and compounding kidney stress. Ask your doctor this directly. Given my current kidney function level, am I on the safest diabetes medication for where my GFR sits today? Kidney function must be checked before starting any diabetes medication and monitored regularly throughout. The adjustments exist, other options are available, but the conversation has to happen first. Write these down. These are the exact questions that protect your kidneys. And most seniors never think to ask them. First, when was my kidney function last tested? And what were my GFR and creatinine numbers? Every senior over 60 on long-term medication should know these two numbers the way they know their blood pressure. Not approximately, not, I think it was fine. The actual numbers. Because your GFR today is not the same number it was 5 years ago. And every medication decision in your life should be made against what it is right now. Second, for every medication I take daily, prescription or over-the-counter, has my kidney function been factored into the dose and the duration? Not when I started it. Now, at my current kidney function level, a dose that was appropriate for your kidneys at 58 may not be appropriate for your kidneys at 72. That recalculation is your right to request, and it is your doctor's responsibility to perform. Third, are any of my current medications dangerous in combination, especially if I get sick, stop eating, or become dehydrated? Because the triple whammy does not require a dramatic event to occur. A summer heat wave, a stomach bug, 3 days of poor appetite. Any of those can tip the balance. Know your combinations before the situation arises, not after. Fourth, and this is the most important question on this list, ask your doctor or pharmacist for a medication review specifically focused on kidney impact for someone your age and your current kidney function. A physician who takes your kidney health seriously will welcome that question without hesitation. If they dismiss it, minimize it, or make you feel like you are being difficult for asking, that response tells you something important about the conversation you may need to have elsewhere. These are not the questions of a difficult patient. They are the questions of a patient who understands that their kidneys, at this stage of life, deserve to be part of every single medication decision made in their name. 5 medication warnings is a heavy thing to carry. I want to acknowledge that, and without softening a single word of what I've just told you. The weight is appropriate. The information is real, and you deserve to sit with it for a moment before we move forward. But here's what I also need you to know. Home kidney function testing now exists, reliable, accessible, and available without a clinic visit. Seniors can track their own GFR trends between appointments, catching shifts early rather than discovering damage that has already compounded over years. The monitoring tools that once lived only inside a laboratory are moving into your hands. The field of pharmacogenomics, the science of matching medications to individual biology, including kidney function profiles, is advancing faster than most people realize. The era of one-size-fits-all prescribing is ending. Personalized medication decisions based on how your specific body processes specific drugs are no longer a distant promise. And the deprescribing movement of formal physician-led review of whether every medication a senior takes is still necessary, still appropriate, and still safe at their current health status is gaining real ground in clinical practice. More physicians are asking the question that should have always been asked, does this person still need this at this dose, given what their kidneys look like today? Many cases of early medication-induced kidney damage are reversible. When the source of damage is identified and removed promptly, the kidney responds. The kidney, and even after years of silent strain, is more capable of recovery than most people are ever told. When we remove the source of damage and give it the right conditions, it responds. But it does not always fully recover, but it fights back harder than you would expect. And that fight is absolutely worth starting at any age. I want to tell you about a patient. I'll call him Arthur. Arthur was 71 years old when I first met him. Retired civil engineer. Sharp, independent, the kind of man who still kept a vegetable garden large enough to supply half his neighborhood. Every Saturday morning, without exception, he played golf with the same 3 friends he'd known for 30 years. He considered himself healthy. He had no reason to think otherwise. For 2.5 years, Arthur had been taking ibuprofen every morning for his knee. Over the counter. His pharmacist had never flagged it. His primary care doctor had noted the arthritis and moved on. He was also on an ACE inhibitor for his blood pressure, a medication he'd been told was protecting him. Nobody had ever placed those two things in the same sentence. Nobody had told him that combination in a man his age was something to watch. The blood test that found it wasn't even ordered for his kidneys. He'd come in for a routine pre-surgery clearance for a minor procedure on his hand. We ran a full panel. When I looked at his creatinine and his GFR, I sat with the numbers for a moment before I called him in. His kidneys were functioning at just over 40% of expected capacity. 2.5 years of daily ibuprofen, an ACE inhibitor, and a body that nobody had been watching closely enough. I remember the moment in my office when I explained the connection, what the ibuprofen had been doing, what the combination meant, how long it had likely been progressing without a single symptom to catch it. Arthur was quiet for a long time, and then he looked at me and said, "I'm not ready to be someone my grandchildren have to worry about." 15 words, no medical language, just a man telling me exactly what he was afraid of losing. We adjusted his medications that same week. Ibuprofen replaced with a topical anti-inflammatory and a carefully dosed acetaminophen regimen. His ACE inhibitor dose reviewed and recalibrated. Hydration protocol established, and then we watched. 8 months later, Arthur's GFR had climbed back to 61%. Not full recovery, but meaningful, measurable progress in a kidney that had been silently absorbing damage for years. Last spring, he sent me a photograph. Standing in his garden, sleeves rolled up, holding a crate of tomatoes the size of a small child, grinning like he'd just won something. He had. A prescription is not a permanent contract. A medication you started at 55 does not automatically belong in your body at 70. Medicine changes. Your body changes. The conversation has to keep up. What I have watched happen in over 2 decades of clinical practice is a quiet, systemic failure to have that conversation. Not out of malice, not out of negligence, but out of a system that moves too fast, assumes too much, and rarely stops to ask whether the medication that made sense then still makes sense now. That ends with you. That kidney function panel has your name on it. Every number on it, your GFR, your creatinine, your kidney's daily report on what it is handling and what it is struggling with belongs to you, not to the prescription, not to the system, to you. You have the absolute right to know what those numbers say, what they mean, and what every medication in your cabinet is doing to them. You are not a passive recipient of medical decisions. You are the person those decisions are made for. Ask the questions, request the panel, bring the list. No physician worth their license will turn away a patient who arrives informed and engaged. Your kidneys have been working for you every single day of your life without asking for anything in return. It is not too late, and it is never too much to start working for them. Let's bring this together. NSAIDs, ibuprofen, and naproxen reduce blood flow to your kidneys with every dose, and daily use in seniors can silently accelerate kidney function loss over months and years. Proton pump inhibitors, taken long-term, have been linked to kidney inflammation and a significantly elevated risk of chronic kidney disease, even in people who feel completely fine. Certain antibiotics, particularly aminoglycosides, are directly toxic to kidney cells, and the risk is sharply higher in seniors than in younger patients receiving the same treatment. ACE inhibitors and ARBs, when combined with NSAIDs or dehydration, create the triple whammy: a simultaneous assault on kidney blood flow that can cause acute kidney injury within days. And certain diabetes medications, including metformin and SGLT2 inhibitors, require kidney function levels that many seniors no longer have, making regular monitoring not optional, but essential. 5 medications. One conversation your doctor may never have started. And now you know to start it yourself. Which of these 5 surprised you most? Is there something you have been taking for years that you have never had a kidney conversation about? Tell me in the comments. Your question might be exactly what someone else needed to see today. If someone came to mind while you were watching this, a parent, a spouse, a friend who takes any of these medications every single day, share this video with them. You don't need to say a word, just send it. That one share might protect someone's kidneys before the damage becomes irreversible. Take care of yourselves. You deserve a doctor who reviews every medication with your kidney health in mind. And now you have the knowledge to walk into that appointment knowing exactly what to ask. Everything I have shared today is based on published clinical research and over 2 decades of patient care, but it is general information, not personal medical advice. Your kidney function, your specific medications, your complete health history. Those details matter enormously, and I do not know them. Please bring what you have learned today into a full, honest conversation with your own doctor or pharmacist. That conversation, specific, direct, and unhurried, is exactly where your kidney health begins.